privileged to Today, we are privileged to host Dr. Sabha Ahmed from the Department of Neuroimaging and Interventional Radiology, and she'll be speaking on encephalitis radiology at the crossroads of infection and immunity. We all know that it can be very challenging sometimes to differentiate between the infectious and immune-mediated processes for encephalitis because they often overlap, and today she'll be taking us through a practical imaging-based approach to the topic. So just a short summary of Dr. Sabha Ahmed's profile. She is an assistant professor in the Department of Neuroimaging and Interventional Radiology at NIMHANS, Bengaluru, India. She completed her MD in radiodiagnosis and has a doctorate in medicine in neuroimaging and interventional radiology from NIMHANS too. Her clinical and research interests span diagnostic radiology, neuroinfections, inflammatory disorders of the central nervous system, stroke imaging, and neurointervention. Dr. Ahmed has authored numerous peer-reviewed publications in neuroradiology and is actively involved in national and international educational initiatives, including serving as the editor for the Indian Society for Neuroradiology Case of the Month series. Our work focuses on integrating advanced neuroimaging techniques with clinical decision-making to improve patient care and understanding of neurological disease. We are delighted to have her share her expertise with us today, and so I encourage everybody to participate, and we will reserve the questions for the end of the discussion, but you can also leave them in the comment section. So, Dr. Sabha Ahmed, thank you for joining us. We can start your presentation now.
Thank you for the kind words and for the lovely introduction, and also for having invited me. I will cut straight to the chase and let's go ahead with my presentation. I will just stop my video so that you have all the attention on the slides, and let's move on. So, starting off with encephalitis, much like what she said, we are often at a diagnostic conundrum when it comes to diagnosing what the etiology of encephalitis is. And the title of the talk here is very deliberate. Encephalitis exposed. My argument over the next hour is that encephalitis is where neuroradiology stops being descriptive and starts to get pretty decisive. It sits exactly at the crossroads of infection and immunity. And the pattern we recognize on MR often decides whether the patient gets, say, an antiviral drug or an immunosuppressant, or just are we hunting for an underlying tumor. So, starting off with what exactly encephalitis is, just give me a minute. I think this is giving me some trouble. All right. So, let's start with understanding what the word exactly means. So, essentially, it encompasses inflammation of the brain. And you could have a multitude of mechanisms. You could have, direct viral invasion. You could have post-infectious immune injury, or you could have antibody-mediated disease as well. But they essentially converge to a common clinical endpoint where your patient is presenting to you in an acutely encephalopathic status with altered mental status. You could have seizures, you could have focal neurological deficits as well. So, our job here is going to be to work backwards from the imaging and figure out what the mechanism is. So I am I like to learn on the job. So essentially, we read our cases, and I like to go back and retrospectively analyze what we could have done better when we have the diagnosis. So this is one of the introductory cases. I would like my audience to be, very savvy here when it comes to the cases that I present. You could have your own opinions. You could put them in the chat box, but this is, just some food for thought. So this patient presented to us. I'm going to be very deliberate with the choice of words as well. So there is a subacute onset of presentation, and the patient is encephalopathic. So let's just say the patient presented to us with seizures. There are some FNDs as well, and this is what we see on the MR. So as you can see, there's extensive involvement of the left temporal lobe. There's involvement of the thalamus as well, and you also see involvement of the insula. So at this point, we know we are dealing with something, some sort of encephalitis. And then, of course, we have the susceptibility weighted imaging, which also shows some microbleeds at the level of the insula. And there's involvement of the cortical subcortical areas as well as the centrum semiovale bilaterally, more confluent on the left. And this is the diffusion. You also see some area showing trace hyperintensity here. I haven't really added the ADC, so I just would want the audience to believe that this is true restriction. And as you see, the entire temporal lobe is also showing some restriction. And now we move on to what's happening at the level of the contrast enhanced sequences. You see these lesions here. Some of us would describe it as ring enhancing. That's absolutely fine. I do think they are ring enhancing lesions, and I zoomed in this for you. And as you can see, there's a lesion sitting at the level of the hippocampus as well. So I will come back to what the diagnosis of the case is right at the end of the slide, of my talk. But I would like the audience to formulate your hypothesis. What could it be? Is it run-of-the-mill organisms that you see on an everyday, work job, or is it something different? But this is the follow-up imaging of performance, and as you can see, the areas that were previously involved are, turning into liquefactive necrosis. So I'm someone who likes to delve a lot into the pathophysiology of a condition. That is what really sticks with me, and I understand that path and radiology go side by side. So that's my reason for showing this to you. And you also see some areas showing subcortical, susceptibility here in the left temporal lobe as well as the insula, where the susceptibility is a lot more profound now as compared to the previous imaging, right? So now essentially this is how the entire lecture is going to be structured. We're going to be seeing a lot of cases, try to delve into the pathophys, and finally at the end of the lecture, I'm hoping that the audience per se have already formulated a diagnostic algorithm as to how you would deal with the case of encephalitis. So my reason for showing you the case was essentially to put forth what happens to the brain during encephalitis. So as you can see, at the inflammation stage, there's proliferation, there's inflammatory cells, there's going to be a lot of neutrophils, and that is going to progress mainly to involve lymphocytes and also macrophages infiltrating the arachnoid and also the brain. But they could concentrate around the blood vessels, which essentially translates into the susceptibility, artifacts that we see, or the microbleeds that we see at the inflicted neuroparenchyma. And this per se is going to progress to microglial activation, forming small clusters, and primarily, lead to neuronal death and demyelination. So starting off with infections, which is what we see very commonly, I'm assuming, that the picture in India is not very different from what we see in Africa as well. So starting off with viral encephalitis, as we all know, herpes simplex virus 1 is very notorious for viral reactivation. So essentially what we see is latent infection in the trigeminal ganglion, and then you have the reactivation of the virus, and finally it spreads to the temporal lobe, which also sort of explains why there is predilection of the temporal lobe in most, but not all cases of HSV1. So as you can see here, we had this patient of, suffering from AML and had a subacute onset of, neurological symptoms. There was altered mental status. We got the MR done. As you see, there's involvement of the temporal lobe. There's also involvement of the basic frontal lobe. There's involvement of the thalamus. There's involvement of the tail of the hippocampi as well. Now, again, very important that we understand that, all of these structures essentially encompass the limbic system, and it is to say that certain organisms have a propensity to involve these structures as opposed to other structures. And you do see, areas of trace hyperintensity as well. Moving on, this is another case, where you see a similar predilection, but now it is, sort of asymmetric, but there's bilaterality here. Of course, there's involvement of the basal ganglia as well, and you see the involvement of the claustrum, the external capsule, as well as the insula. And of course, you could have some amount of diffusion restriction happening there as well. Cut to HSV2, which is going to be a rather neonatal focused virus, where you have maternal genital HSV infection, and there could be the vertical transmission. But what's really unusual with HSV2 is that you could have an early stage of cortical laminar necrosis progressing to cystic encapsulation. Finally, you could also have dystrophic calcification. So now these are representative cases from this beautiful study in a journal, Pediatric Radiology. So essentially, what you see is bilaterality. You see the effacement of the sulcal spaces in the parietal lobes bilaterally, and there's confluent involvement of the subcortical as well as the deep white matter. And at the diffusion on the level of the diffusion weighted imaging, you see extensive diffusion restriction of the cortex as well as the deep gray nuclei. Now, cut to this, what happened 30 days after, the patient presented with this imaging picture, you see this deliberation of, cystic encephalomalacia. So I will say that not all viruses tend to cause cystic encephalomalacia. There's a terminology which recently came out. It's called the cortical melt sign by the Rossi group. Again, a phenomenal paper. I will show you, some of the cases that we have had seen in our experience with different organisms, but that was primarily described in HSV1. And then, of course, you could have, other imaging manifestations as well, where you have periventricular area showing diffusion restriction. Of course, here there's a multitude of differential diagnoses. It could be HSV, it could be perico, it could be entero as well. So just keep in mind that these are the kind of imaging manifestations that you would see in cases of viral encephalitis. And of course, this is another case where much like what I said, it starts off with cortical swelling and there's involvement of the deep gray nuclei. What you see as enhancement could essentially be, how it's progressing to cortical laminar necrosis. As you see here, the Steven hyperintensity of the afflicted cortex. And then, of course, it essentially dies down to neuronal death and demyelination. And then, of course, you have the cystic encephalomalacia happening. So now this is a very special case. So we had, the quintessential picture of what anyone would describe as encephalitis. And then, of course, we got the imaging. At this point in time, we had, a discussion with the neurologist, and they were not very sure if it's infection or it's autoimmune. So we've got to be careful. So I said, it could be either the patient did have viral prodrome and, there was involvement of the limbic system here. So we didn't have a doubt as to what it could be. I said it could be herpes simplex because that's one of the commonest organisms that we see. And of course, you will have to rule out autoimmune as well. But it turned out to be positive for mumps. And we went back and asked the clinicians, did the patient have parotid swelling? And lo and behold, the patient did. So some of the clinical cues are going to be able to tell you as to which organism it could be. And again, of course, having the clinical picture, the onset to nadir, that is also extremely important. With autoimmune, it's going to be subacute to begin with. With viral, you could have an acute to subacute onset. So then, of course, we have a bunch of other viruses. Now, VZV, as we all know, the varicella virus, again, prone to, sitting latent within the trigeminal ganglion. And then, of course, you could have reactivation and, the CNS complications, which could be a multitude. Now, this is one of the commonest manifestations that I would say in terms of the VZV, where you have, perforator infarcts, or you could have infarcts in the smaller, cortical branches. As you see here, there's involvement of the thalamus, there's involvement of the basal ganglia, and you also see some involvement of the subcortical areas. And of course, we didn't get a vessel wall imaging in this case, for reasons unknown. But as you see, the beaded appearance of the intracranial vessels here, more so, involving the distal M1, M2, as well as the cortical branches. And then, of course, we did have a CT angiogram as well. Can you appreciate the difference in the caliber? And then, of course, you have, the pre-stenotic dilatation as well that you would see in some of these cases. And then you see the attenuated caliber of the basilar artery as well. So this was a very young patient. Had it been an old patient and we didn't have this, we would have thought of other disorders as well, vascular disorders per se. But then, of course, with the clinical manifestations that the patient presented with, we did give a possibility of VZV, and it did turn out positive. But and then, of course, these are run-of-the-mill cases where VZV infection can precipitate what we call the focal cerebral arteriopathy, where you see this short segment stenosis, and then, of course, the corroboratory infarcts in the perforator territories. But This is also interesting that you could have an encephalomyelitis where there is involvement of the spinal cord as well, and of course without the right clinical history, and of course, and if you didn't have the clinical picture of, say, the fever, the rash that you see, the crusting rashes that you see in VZV, it would be a lot difficult to make the diagnosis. But then of course you have quintessential imaging findings of the central nervous system, and when it comes to the spinal cord, if you have an extension of what's happening in the brain, you could run a possibility of VZP in such cases as well. And then, of course, we have, Epstein-Barr virus. Now, with respect to Epstein-Barr virus, again, most of these viruses are going to be remaining quiescent for quite some time within the circulating B lymphocytes, and they have a predilection to involve the nasopharyngeal lymphoid tissue. And there is, some amount of encephalomyelitis that could happen with the case of Epstein-Barr virus as well. So as you see here, there's involvement of the deep gray nuclei. There's also involvement of the corpus callosum. Then you have the involvement of the brainstem. And of course, you do see some involvement of the spinal cord. Now, it's really your clinicians that is going to be helping you figure out, if it's just encephalitis or encephalomyelitis with respect to the clinical manifestations of the patient. And much of what I've understood is when you have a picture of encephalomyelitis, it's more often than not an infectious etiology over what we would consider an autoimmune cause. And this is another beautiful case of, encephalomyelitis. And again, what I wanted to emphasize here is the predilection of these viruses to involve the deep brain nuclei. And of course, you have the involvement of the corpus callosum as well. And look at how beautifully it has involved the brainstem as well. And then you also have involvement of the spinal cord. So in such cases, I think it would be dubious to call it anything but a viral infection. But of course, it becomes a little tricky to call it, to call it a particular virus over others, because you do have a multiplicity of other viruses as well that could have a similar imaging picture. But calling it a viral encephalitis is where you're winning. That's where you're telling your physician that, listen, I think it's infection, so you've got to work that up. And autoimmune could be on the lower aspect of your differential diagnosis. And like I said, you could have other viruses as well that could have involvement of the brainstem. I will not go into detail about the other manifestations. I want it to be a purely imaging based approach. So as you see here, again, lovely involvement of the brainstem. There's involvement of the dorsal brainstem, and you see the involvement of the midbrain here, the periaqueductal gray. Then you see the involvement of the pontine tegmentum as well. Down, it's going down, we also see involvement of the medulla. And then of course there's involvement of the spinal cord. So it becomes very important that when we see something like this, always raises suspicion of viral etiology. And then, of course, we have measles as well. So I will say that in the last 8 years of me being a radiologist, I haven't come across an acute measles encephalitis. But I will say that in the Indian subcontinent, although the Western Hemisphere tends to, call SSP a very rare disorder, we do see a lot of SSP. It could also be something called as a tertiary bias, because a referral bias, because we are primarily a neuro institute and we get all of the cases referred here, but we do see a lot of SSP day in and day out. So with acute measles encephalitis, it is usually going to be a non-immune immunocompromised patient, particularly mostly children and adolescents. And essentially what you see, the picture is not very different from what you would see in an SSP, but what you also see in measles is confluent involvement. From what I've understood in SSP, and I will be showing a couple of slides as well a few minutes from now, is that you could have periventricular, or you could have subcortical, or you could have a mix of both. Whereas in cases of acute measles infection, as you see, there's confluent involvement of the subcortical as well as deep white matter, and you could have different ages. Now, why do I say different ages? As you see the involvement on the right side of the parietal as well as the occipital cortices, there's diffusion restriction. Whereas on the left, there is T2 shine through. So what I would call it is a multiphasic condition as opposed to just calling it, a uniphasic etiology. And you do see here, this of course, is basically telling you that the cortex on the right is acutely involved as opposed to what you see on the left. And then you also see gliosis involving the left frontal. There's involvement of the right frontal as well. So you do see this multiphasicity of the infection that it has caused. Whereas in the case of subacute sclerosing panencephalitis, I'm being very deliberate. It's not as rare as people say, but I will also say that there is a demographic and epidemiological niche to such disorders. And I will have wanted to, the reason for me covering it is because we see a lot of that back in India. I'm not sure what the demography in, your country is, but it's important to know that, some of these conditions can be great mimics as well. So, what is really important for us to understand is SSP is going to have a quintessential clinical picture of myoclonus, seizures, and this will have a gradation according, there's stages 1, 2, 3, and 4, where initially it just starts with, you could have seizures, you could have myoclonus, and then finally, when the patient reaches stage 4, you could have, a mutic patient, right? And the disease essentially is incurable and it usually causes death within 2 to 4 years of onset. Now, the typical pattern, of SSP is going to be asymmetric posterior predominant subcortical change. And much like I said, you could have, just subcortical changes, or you could have periventricular changes, or you could have a mix of both. But the other thing that is important is there is a posterior to anterior gradient when it comes to SSP. Posterior lobes that tend to be more involved as opposed to, the anterior part of the neuroparenchyma. Now, this is one of the studies that we performed, a pretty novel study. I would say it's the first of its kind that will come out, as a published paper in the recent future. But what's really important for us to understand is that we don't really tend to perform, perfusion imaging, particularly ASL in encephalitic patients. I mean, that was yesteryear. But what we've understood, with our experience with ASL, since of course it's non-contrast enhanced as well, you just need to run a sequence. It won't cost you much time too. So, is that you could use the perfusion picture to determine which stage of disease, SSP is in. Of course, this is a single institution study, so I will want, global centers where SSP is more common to take on the study and see if you also find a similar findings in such cases. But what we saw was some of these cases showed exuberant, this raised perfusion in basal ganglia. It was one of the most common perfusion patterns that we saw. Of course, there were other perfusion patterns as well, particularly involving the cortex. And we essentially saw that this perfusion pattern was most common in stage 2 of the disease, few in stage 3. And of course, when you go to stage 4, you have, cortical laminar necrosis setting in, and you could also have the cortical melt sign, which is seen here, which I will be speaking about. Now, of course, in addition to involvement of the supratentorium, you could also have involvement of, the brainstem, particularly the middle cerebellar peduncus. Of course, this is more commonly seen with adult onset SSPE, but we do see some of the cases with pediatric onset as well, showing this kind of a picture. Now, this is a very special case, and I call it special because at the outset, we thought, with the expansile changes that we saw in the white matter and how it's crossing the corpus callosum, we were pretty sure we're not dealing with, an infection. We thought, come on, this has got to be a tumor. And we saw, this was one of the preliminary cases that actually pushed me into looking at the patterns of ASL perfusion in SSP. And as you can see, there's this remarkably elevated perfusion in the white matter. So at this point in time, we thought, come on, this has got to be a tumor. Let's get our neurosurgeons to biopsy it. But lo and behold, it turned out to be positive for SSP. So this is what I would like to call a pseudotumoral SSP. And that's precisely why it's very important that you understand that not everything that shows raised perfusion is a tumor. And something that looks as expansive and as dirty as this could still turn out to be SSP. So what I would suggest is get an EEG and run the CSF anti-measles titer. Of course, if this is more common in your region, that is when you could consider the possibility of also raising SSP. Now, this is again one of the other novel imaging biomarkers that our group found is the presence of the subcortical rim. As you see here, this is a burnt out stage, right? Now, this is going to be stage 3 or stage 4. It's not going to be one of the earlier stages of SSP. Now, why this is important is we ran the lifetime progression of these patients, and what we figured was these are the patients that presented much later in onset in terms of the index presentation to the clinician, and they had a much slower course, but of course they did catapult to stage 3 and 4 of the disease. So we do have two papers coming up on perfusion as well as subcortical rim. I would invite the audience to please have a look, read our papers, and come back to us. Constructive criticism is what really helps us grow as radiologists, and any and every kind of opinion is welcome. Now coming to the most catastrophic form of this disorder is the fulminant SSP. Now, I call this fulminant because over a couple of months, as you see, it's a matter of 1 month, 2 months between 16 to May to July 2025, where you see this burnt out stage, and of course this patient succumbed to the illness. And what you also see is the extensive confluent involvement subcortical deep, and you also see the involvement of the brainstem and the MCPs, like I said, and just over a couple of months, you see this dramatic volume loss. Now, again, something very common with autoimmune disorders is over a couple of months, you see this dramatic volume loss, in most of these conditions. So these are very nasty in terms of how the patient is going to progress clinically. And particularly with SSP, we've also seen that some of these conditions show subcortical diffusion restriction. So that is also something to watch out for. And now this is again one of those cases where we found that there was raised perfusion and there's involvement of the corpus callosum as well. So we thought again, this could be a tumor, but it turned out to be SSP. So we've been quite wrong when it comes to diagnosing this condition, although we do see it a lot in our clinical practice. So it's very important that we also know that you could have atypical manifestations as well. But what I really wanted to point out is the cortical meld. So essentially, we had this lovely paper come out by the Rossi group on the cortical meld sign in HSV1, where they essentially said that areas of the cortex involved and showing diffusion restriction, what happens to them over a couple of months is liquefactive necrosis, right? But we did write them a letter to editor where we said that this could also be seen in subacute sclerosing panencephalitis. So moving on to PML, I think we are all very well aware of what the idiopathogenesis of this disorder is, but I would just like to, briefly tell you about how the imaging is. So this is what we call the Milky Way sign, and then of course you have the shrimp sign where there's involvement of the cerebellum, but there's sparing of the dentate hilus. And again, what's important is that when you have something like a PML showing up, there's not going to be any enhancement. And if you see enhancement, quintessentially, you're going to be thinking about PML iris and not run-of-the-mill PML. And like I said, we always come up with new signs. I'm not very good with signs, but the Milky Way sign is a it's a very pretty image that you see here, right? So you have punctate high T2 signal lesions surrounding the afflicted area, and of course, like I said, you could have the shrimp sign as well. And again, something that I wanted to show you is that you could have an encephalopathic presentation with PML, primarily because of the involvement of the deep brain nuclei and also the thalamus. It's not something that is very commonly described, but again, it's important that we understand that when you have run-of-the-mill diagnosis for some of these cases, given the science that we love reading and using to diagnose these conditions, it's also important to go back and look at what is atypical in a condition. And this is what we found, that you could have thalamic involvement as well in PML. So moving on to viral zoonosis. Now, I will say that rabies may not be as common in the West. Of course, you do have different reservoirs there, like bats, but in the Indian subcontinent, we do see a lot of rabies. I wouldn't say a lot, but we do see a proportion of rabies encephalitis as well. In fact, quite recently, we had a case where, after a dog bite, despite having adequate post-exposure prophylaxis, the patient did succumb to rabies encephalomyelitis. So again, it becomes very important to understand that certain viruses, much like I said, when it comes to HSV, it's going to be involving the temporal lobe, whereas when it comes to rabies, as you will see here, there's going to be involvement of the deep brain nuclei. As you see, there's extensive, just voluminous involvement of bilateral basal ganglia, and then of course you have the involvement of the brainstem as well. So very, very important for us to understand that certain viruses have a predilection to the deep brain nuclei, certain viruses have a predilection to involve the limbic system. So that is how you're going to be able to differentiate one organism from the other. And as you see here, you could call this lentiform fork, whatever suits you, whatever floats your boat. But then you also see there's involvement of the spinal cord as well in such cases. So anytime you see something like this, and of course, I think this is one of those cases where clinical context becomes supremely important for you to be able to call it, rhabdoviridae family. So go back and ask for the history of a dog bite. Usually, these are the cases where the clinician, themselves come up to you and tell you that, this is what the history is. I think it is rabies encephalitis. And then, of course, you go back, look at the imaging, and reinstate that yes, of course, it does look like a viral encephalitis. Now, with respect to J, again, we know it's going to be a Culex mosquito bone flaviviral encephalitis. Again, I wanted to show you some of the common findings. Of course, I think the ANAC-like picture is something that is very, very commonly associated with Japanese encephalitis. But I did want to show you that, when you follow these patients longitudinally over time, this is what you will see. As you see, there's involvement of, the thalamic, bilateral thalamic lesions, particularly when you see, the presence of microhemorrhages. You will think along the lines of, say, an NX-like picture. You could have a multitude of viruses that could have caused this. But again, you will also have to understand that, deep CVT is also something that you will bear in mind when you see, deep gray nuclei involvement. But when you see deep gray nuclei in the context of cortical lesions that you see here, cortical, subcortical, hyperintense signal changes, that is when you will think along the lines of an infection. And now, as you see, the first imaging was in 2014, and now we come to 2018, and you do see some sequelae of what you saw 4 years ago in the form of gliosis, right? And this is in 2023, where essentially you see how shrunken the thalami are, compared to the previous imaging. And then, of course, you have, a liquefactive necrosis set in. And again, I would call this also the cortical melt sign, right? So I will say that that could be synonymous to what you see over time longitudinally in cases of viral infection. And then, of course, you have dengue. And again, something that is important with dengue is that it is non-neurotropic per se, but it could have hemorrhagic manifestations in the central nervous system with dengue and encephalitis. And again, something that I wanted to show is we are very well aware of the donut sign and that you have the ANAC-like picture in dengue. But I did want to say that you could have something like this, which could sort of provide impetus for you to be calling this, say, a herpes or some other virus, but you could have a very, very similar picture happening with dengue and encephalitis as well. And then, some of the other viruses that we come across in the Indian subcontinent are the chikungunya virus. And again, you do see, the involvement of bilateral thalami as well as the cerebellum. Now, this is a very, very, I show this to any radiologist and they would jump to call it an ANEC, they jump to call it a Japanese encephalitis. But what I would like to say is if your patient is going to be presenting with arthralgias and a picture like this, you have to take into account that, it could be a dengue or it could be a chikungunya as well. So moving on to retroviruses, as we're all very well aware, of the differences between HIV, encephalitis, and PML. Now, the thing about encephalopathy is going to be periventricular, and there's going to be sparing of the U fibers, and it's going to be a lot more symmetric as opposed to what you see in cases of PML, like I showed you. And then you have the involvement of the posterior fossa, which again we commonly see in PML, and then you have the sparing of the dentate hyalus, akin to the shrimp sign that could help you diagnosing between HIV encephalopathy versus PML, in addition to the fact that your CD4 in encephalitis is going to be less than 500, whereas in PML it's going to be less than 100. And of course, in both of the conditions, you will not see any kind of contrast enhancement. If you do see that, think along the lines of an iris. Now, CJD again was very important for me to put up because these patients present with a rapidly progressive dementia. The initial onset is going to be very encephalitic, and this is run-of-the-mill picture where you see diffusion restriction involving the deep brain nuclei. Of course, you have a bunch of other signs, and I'm pretty sure the audience here knows them. But again, this is one of those cases where we were at diagnostic conundrum. We didn't have some of these cases, when you ask the clinician for history, they're going to give you run of the mill histories of what an encephalitis could present like. But when you actually go back, when you're thinking along the lines of what could it be, none of us is going to call it autoimmune, right? We're definitely calling something like this infection. Now, again, when it comes to infection, what could it be? You have T2 hyperintensities involving the cortex subcortical areas, and you see this dirty looking picture involving the white matter, and it's also showing diffusion restrictions, some enhancement, and microbleeds. So, in the Indian subcontinent, we would call it a fungal, or we would also keep a differential of amoebic. Now, again, very important to understand is that amoebic cases, some of them are going to be fatal, absolutely fatal in the ICU, not doing well. So, in such cases, it becomes important that you go back and ask, is there relevant history of exposure? Do they have any kind of freshwater exposure? And any kind of immunosuppression as well, particularly diabetes, which is very rampant in the Indian subcontinent, that could propel us to call it a fungal case. But as you can see, we did err on the side of infection here, but the patient did succumb to the illness, and we did have histopad done on this case, and this did turn out to be positive for granulomatous amoebic meningoencephalitis. So that's the infection part of it. Now, I dealt with, I would say, the commoner as well as the uncommoner presentations of, some of the common infections that we come across in our country. I will say that this might not match the geography, but I would say that, the imaging manifestations are going to be protean, but also common in most parts of the world. Now, coming to autoimmune encephalitis, a prelude to this is couple of years ago, 10, 15 years ago, autoimmune was a very enigmatic entity. We didn't know what was happening, and anytime we saw, dramatic progression, psychiatric symptoms, we thought, okay, this could be an autoimmune condition. And of course, we have evidence to historically believe that you would have very dramatic progression with autoimmune encephalitis. But cut to chase, in 2026, we are at a very, very comfortable position to call something autoimmune, and then of course differentiate one antigen from the other, and also predict on this essentially provides the basis for how your clinician is going to be treating the patient. So again, as we all know, what an autoimmune encephalitis is, a group of autoantibody mediated disorders. Now, again, what's important for me is that you understand that there are two types of antigens that the antibodies could be formed against. And then, of course, the clinical pictures here is going to be very similar to what you see in infection, but you may not have a viral, an infectious prodrome. But I will say that some of the conditions of autoimmune encephalitis that I have come across have also been cases where the impetus for a condition to show up has been a preceding, viral prodrome. You could have the patient presenting with fever, and that's, cut to chase, you have a bunch of clinical manifestations that owe you on the side of autoimmune encephalitis. So when you see, the pathophysiology part of it, you have the intracellular antigen, and then of course you have the antibodies against the cell surface antigen. As you can see here, the antibodies against the intracellular antigens, they're not necessarily going to have access to the intracellular epitopes. And essentially what you see are just markers of a T cell mediated process. As opposed to what you see happens in the case of cell surface antigen is that your antibodies have direct access to the cell surface, right? And they have access to their epitopes, and that is what essentially mediates the neuronal dysfunction. I will not go in detail with the anatomic, and serology classification because we will be seeing a lot of cases. But you could also have an etiology classification where you just say that it's either idiopathic or it could be parainfectious, paraneoplastic, or post-infectious. So when you go to the pathophysiology and the classification, much like I said, when you have the intracellular antigens, it's going to be a T cell mediated process, whereas group 2 antigen is going to be a direct neuronal dysfunction. And much like what you see in, encephalitis caused by infectious causes, you're going to have protean involvement of the limbic system, and you could also have the extratemporal involvement with translating to the clinical manifestations mentioned here. But differing from what you see in the case of infectious encephalitis, with autoimmune, the onset is always and always going to be subacute, and the progression of symptoms is also going to be over a couple of months or weeks, some even years, as opposed to what you would see in infections. So starting off with the intracellular antigens, as I said, now these are conditions where the antibodies don't have access to the epitopes, right? And these are notorious because they are not going to be responding really well to therapy. And most of these are associated with cancers. So we have the anti-Hu autoimmune encephalitis, which is the most common cause, and this is associated with small cell lung cancer. Now, this is a case where, we have confirmed anti-Hu autoimmune encephalitis, and you see this increased signal involving, bilateral medial temporal lobes, and you also see involvement of bilateral cingulate as well. Now, as is dictum in our institution, for most of these cases, we get a PET done. And essentially, what I wanted to show here is there's not much of difference in the metabolic uptake when it comes to the areas involved, but you will see that there is some involvement of the basal ganglia as well as thalamus. But for people who do read PET, you do understand that uptake in the basal ganglia and thalamus, to a certain extent, is normal. Of course, we have the SUV uptake that we measure. That's how we quantify which is normal and which is abnormal. But what I really wanted to show you in the next couple of cases as well is the variable manifestations on PET as well, particularly with respect to autoimmune encephalitis. Now, anti-MA or TA, this is another subset of intracellular antigen. Now, again, I will say that it's not necessary for us to really remember which tumors are associated with which antibody. It's available freely. You could always have an access to that. We have a really supportive neurology department as well as a pathology department that that hands us brochure with which antibody is associated with which tumor. But it's very important that, particularly in cases of autoimmune encephalitis presenting in middle-aged to elderly people, it's really important that you do a paraneoplastic check. So, much like I said, in our institute, we perform a whole body PET as well as MR PET as well as a brain PET. Now, we have this case where we had this elderly gentleman present to us with ataxia. There were a bunch of other symptoms, and the progression was over a couple of weeks. So, at this point in time, we got the MR, and as you see, there's fluoride involvement of the cerebellum, the cerebellar folia, there's nodular enhancement, there's microbleeds. At this point in time, we thought, come on, it's going to be vasculitis, or it could be scrub. We didn't really think along the lines of autoimmune encephalitis here, but essentially this is one of those cases where it turned out to be positive for anti-MA2. But we did a screening for this patient, whole body PET, but we couldn't really pick on which tumor it was. Now, why I say this is because you could have a temporal association or you couldn't, meaning that you could have a patient presenting to you with symptoms akin to encephalitis, and then you could have corroboratory findings on imaging as well, CNS imaging. And when you go hunting for these for the tumors, they may be negative, but it's really important that you perform screening for these patients at regular intervals, because that tumor is going to show up at some point of time or the other. And it's very important that the tumor is removed, because that is what is essentially providing impetus for the autoantibodies in this set of antigens. And then, of course, you have the next group, which is anti-GAD. Now, this is going to be related to autoimmune conditions like type 1 diabetes mellitus as well as hypothyroidism. Now, this is one case where you have a multiplicity of positivity here, where it is anti-GAD positive and also anti-NMDA positive. And as you see here, there's involvement of medial temporal lobes. There's also involvement of the insula bilaterally, some involvement of the temporal lobe on the left side as well. And you do see, the cortical involvement and some flare hyperintensities along the cortex. Now, again, like I sort of, showed in the initial slides, it's also important that you do see how these patients fare over a period of time. Clinically, they're not going to be doing well, but even radiologically, what you're essentially going to see is this extensive volume loss in the areas of the brain that was previously affected. Of course, you could have migratory lesions as well, but what's dictum is most of these cases are going to end up in volume loss. Now, another case of anti-GAR. Now, again, very, very striking finding here is, in addition to involvement of the hippocampi, you do see this stark, cerebellar atrophy, and you could have some dubious involvement of, the midbrain as well. But what's really striking is how lit up, the occipital cortices as well as the hippocampi are on PET imaging. So some of these, when something lights up on PET, particularly in the context of encephalitis, it's going to really help us, give the differential of autoimmune in such cases, because you will not see a very similar pattern with infectious encephalitis. Now, this is another case where we had anti-U antibody positive associated paraneoplastic encephalitis, but really when we went about hunting for the tumor, we couldn't really find it. So that's precisely why I said that at time point one, if you don't have a tumor positivity, you will have to screen these patients at regular intervals to figure out, what tumor it is and essentially remove it, because that is going to be the treatment of choice as opposed to plasmapheresis or say a rituxi infusion in such disorders. And here again, you have the involvement of the cingulate, you have the involvement of the insula, there's involvement of the temporal lobes, the basifrontal lobes, the parahippocampal gyri. All of these, structures are going to be hinting towards, essentially screaming that I'm an autoimmune encephalitis, but you need to figure out, is it, group 1 or group 2? Now, this is just something that I wanted to show in terms of how, at our institution, something like an encephalitis would be, evaluated. So, as you see here, we run, the blood panel. We also run the ANA. We also see, if there's any ANCA positivity. We look for the autoimmune encephalitis panel, which I will also be showing. Then we run a bunch of viruses that are common in the Indian subcontinent, particularly, you have the dengue, you have the chikungunya, then you look at the CSF analysis, try to figure out, is the protein elevated, what is happening to the glucose. And then, of course, you run, like I said, a bunch of, viruses and as well as bacteria. Like in our case, we run the biofire film array, which encompasses all of the commoner bacteria that could have an encephalitic-like picture. And then we have our clinicians running the EEGs as well. And finally, we also look at the paraneoplastic profile. So this is the ANA profile. We run a lot of, antibodies, and essentially, like I said, our departments are very, very generous with us. They also tell us which of these antibodies are associated with which of the conditions, right? So we run that, and then we come to the autoimmune encephalitis panel. Of course, VGKC is a yesteryear term. It essentially encompasses Casper as well as LG1. So we run all of these, autoimmune encephalitis antibodies, and then we also run the paraneoplastic workup. So as you see here, this patient turned out to be positive for anti-U, and then you have a bunch of other conditions. Something that I showed was anti-Hu, which we know is commonly associated with small cell lung cancer. So it's really important that the radiologist knows which is the most common cancer, or at least go through, something like this, because you're going to be helping the clinician in trying to figure out which cancer it is, right? In this case, in cases of anti-Hu, just tell them to run a quick chest X-ray, or just get a CT chest. And of course, this is how we extensively work up any case of encephalitis that comes to our institution. Now, a few other antibodies that I would like to show is, this is again a case of paraneoplastic encephalitis where the patient was positive for the RI antibody. As you see, there's involvement of the anterior temporal pole. There's also involvement of the insula, dubious involvement of the medial temporal lobe as well. Now, this is one of, the commoner, very, very, common case where you do see this, the patient has undergone an MRM, and a couple years later, the patient presents to us with brainstem findings, and the progression is about subacute. So at this point in time, because we know it has, there's temporal association that I said that could be or couldn't be present in a certain case, we did know at this point that, it's going to be a run-of-the-mill autoimmune encephalitis, paraneoplastic encephalitis in this case. And despite having actually removed the tumor, the patient did have an encephalitis-like presentation. And as you see, there's involvement of the temporal lobes. There's some volume loss in the right hippocampus. There's involvement of the brainstem as well. That did corroborate with the clinical manifestations the patient had. Now, this is another case where the patient turned out to be positive for, ampifycin. And of course, what you see here is some subtle involvement of bilateral medial temporal lobes. But when we got the PET done, you do see these really, really huge lymph nodes showing avid PET uptake. So we did go and biopsy that. So that's the importance of knowing, how you image these cases and what your next step is going to be. Having good a really strong neurology and a neurosurgery department is also very important, because it's the reciprocation and also feedback that you get from the departments and the faculty and the clinical discussions that really drive into what you are as a radiologist. Now, this is another case where the only thing we saw was involvement of bilateral medial temporal lobes. But lo and behold, when we got, the MR done along with the PET, we did see some adrenal lesions here. So knowing, is it infectious, is it autoimmune, and also which kind of autoimmune is also important, because much like I said, if it's a paraneoplastic driven process, you need to get rid of the tumor. Whereas I will show you what the other cases and the other subtype of antigens are. So now I will say that group 2 autoimmune encephalitis are one of the relatively, easier encephalitis to deal with, because these patients will do a lot better than what you see in terms of, the paraneoplastic conditions, particularly because if you don't have the temporal association with paraneoplastic encephalitis, and also the fact that when you go hunting for a tumor, you may not find it, patient is going to deteriorate and you really don't know what to do. You're just going to be running plasmapheresis, you're going to be running rituximab in some cases and other drugs, but the patient is not really going to improve. Whereas I will say that, the prognosis in autoimmune encephalitis against cell surface directed antigens are marginally better as opposed to what you see in paraneoplastic conditions. So, moving on, I think what's really important with the group 2 antigens is that more often than not you're going to have an absolutely normal, a pristine looking MR. And as a resident, I thought, I couldn't really analyze and sort of understand why we had this clinical radiological discord where the patient is terrible in terms of the presentation and the semiology and also the chronology of the symptom onset, whereas the MR looked so absolutely unremarkable. But that's where a lot of reading happened, and we did understand that in these kind of disorders you're going to have approximately 50% of these conditions presenting with an absolutely normal MR. But in the appropriate clinical context, it is very important that you also write that a normal MR doesn't exclude the possibility of an autoimmune encephalitis. So that's exactly what I put in here. And then, of course, you do have some run-of-the-mill findings, like for instance, with an LG1, you're going to have the FBDDS prodrome, which I will be talking about, and you will have a multitude of other findings. Like in Casper 2, you will have more van, where you have a triad of encephalopathy, autonomic dysfunction, as well as peripheral nerve hyperexcitability. So this is where the communication with the clinician really helps, because they're going to be coming to you with these clinical presentation, with this clinical presentation, and knowing that a certain subset of antigens is going to have a certain clinical predisposition really helps you in being a better radiologist. So now these are the positive cases, the MR positive cases that I'm going to be showing. So this is an NMDAR antibody positive, where you see extensive involvement of the basal ganglia. Again, a very, very common pattern that you see. Now, I wanted to show you the PET in some of the other cases. As you see, the occipital lobes here are absolutely normal on MR, but what you see on PET is this brilliant, brilliant uptake, metabolic uptake. And this is why PET is important. You could have an pristine looking structural MR, but when you go down to the level of the metabolic imaging, you will know that, all right, the structural MR is precluding the diagnosis, but, PET is really in favor of an autoimmune process. These are, the other imaging findings that you would see on PET, florid involvement of the basal ganglia here. There's also, elevated uptake in the frontal as well as the parietal areas. It could be symmetric, it could be asymmetric, doesn't really matter. This is really, a picture like this would really should really prompt a differential of autoimmune encephalitis. Now, much like I said, you could have a mix of findings. Now, as you see, if you've been reading PET, you will know that some amount of metabolic uptake in the cerebella folia is common. But as you see here, there is decreased uptake. So it's not really just a hypermetabolism. You could have hypometabolism as well. And then you could have different areas of the brain. Like you could have, in this case, it's the cerebellum as well as the occipital lobe, because for somebody that reads PET or a PET on a daily, you will know that an FDG is going to show some amount of uptake in the cortices. And when you do the SUV uptake as well, you will know that, this is an abnormal finding. Now, speaking of, some of the lesions that could be associated with these conditions with NMDA, like this case was a run-of-the-mill case where we had an NMDA antibody positivity. You also had an anti positivity as well. Now, I call this run of the mill because we saw the brain, and incidentally, we had an MR as well. And here, essentially, what you see, is this lesion here sitting in the adnexa. And on T1 weighted sequence, you see the fat, and that's also confirmed on CT. So at this point in time, we all know it's a teratoma, and the most common autoimmune condition associated with that will be your NMDAR associated encephalitis. And like I've been trying to reiterate, in autoimmune, over a period of time, you're just going to be seeing volume loss, as opposed to infectious conditions where you do see cystic encephalomalacia, the cortical melt sign, and of course, you have the hemorrhagic predilection in certain viruses. Now, anti-LG1 encephalitis. Now, with LG1 encephalitis, what's really important to understand is that you have the faciobrachial dystonic seizures. Now, these are essentially frequent dystonic jerks of the arm as well as the ipsilateral face, right? And this is something that should be picked up by the clinician. And, when they pick it up, they know they're looking for an LG1 encephalitis. Now, again, with LG1 encephalitis, LGI1, the run-of-the-mill finding on MR is going to be either a normal MR or the predilection to involve the medial temporal lobes bilaterally. And as you see here, we do ASL in some of our cases. Some of this is just for academic, purposes. And, these are going to light up. The area of the brain involved is definitely going to light up, particularly if it's going to be the limbic system. And this is another case of Morvan. Much like I said, we run, the PET for all of these cases. And you see here, as opposed to some of the cases that I showed you previously, the basal ganglia and thalami are strikingly bright. And of course, you have some uptake in the cortices, which is a lot more than what you would expect. And moving on, like I said, with LG1, it's definitely going to be LGY1. It's definitely going to be the medial temporal lobes. And you see this beautiful elevated perfusion on ASL. Another one of those cases where you see the hypometabolism in the cerebellum, and you see this bright basal ganglia, and you see the thalamus. Now, this is how it would normally look, but here you see how bright it is, and bright and shining, and literally urging you to call it an autoimmune condition. Again, one of the other cases where you have, structural involvement of the medial temporal lobe, and you also see elevated metabolism here and the involvement of the basal ganglia and thalami as well. Now, another pattern where you do see involvement of the cortex, and you also see involvement of, the deep gray nuclei. And here it's a lot more florid. I would say, I would call it diffuse hypermetabolism, but you see the structural MR. It's a normal looking MR, right? But that's the importance of getting a PET or a metabolic imaging, correlate in such cases. Now, moving on to autoimmune encephalitis that are seronegative. So you could have a bunch of conditions where, you run everything, and everything, pretty much everything under the sun turns out to be negative. It's not that uncommon. And despite having extensively evaluated these cases, you are at loss of how you would treat them. And that's when you run generic treatment for these cases. But then again, it's important that you call it autoimmune, because it may so happen that, after a couple of years, you may have something showing up on your blood examinations. Now, again, the picture here is not very different from what we saw in the previous cases, right? The clinical picture is going to help you narrow down to, it could be an autoimmune condition. And then, of course, when you see the involvement of the cortex, the deep brain nuclei, you will err on the side of an autoimmune encephalitis. As you see here, there's thalamic involvement, there's the medial temporal lobe, and you also have involvement of the cortical and the subcortical areas. There's diffusion restriction as well, involving the cortices as well as medial temporal lobe. And when you just follow up, you see the dramatic volume loss that occurs in such cases. And again, it's very important that you see the timeline here. Now, this is December of 2022. And you go back, this is August of 2022. So you do see this dramatic volume loss that occurs in autoimmune encephalitis over a very short period of time. So moving on to the anti-GABA B encephalitis. So with respect to anti-GABA B encephalitis, it's going to be very similar to what you see in terms of the structural imaging. It's going to be very similar to what you see in, the other cases that we saw. Could have involvement of the claustrum, it could have involvement of the medial temporal lobe. And, like I said, now these patients are going to be marginally better in terms of the clinical picture and how the progression is as opposed to paraneoplastic conditions. And you will have a longer period of longitudinal imaging in these cases as opposed to the cases that we saw previously. And, the only telltale in such cases would be the volume loss that you would see over a period of time. Now, of course, BGKC we know is a yesteryear term. It encompasses LG1 as well as Casper. And I just wanted to show that, this patient was on monthly plasmapheresis. And essentially what we saw was just the volume loss, at the level of the medial temporal lobe. And this is another case where, in addition to this, the patient also had hypothyroidism, Hashimoto's, you would say. And we do have a bunch of studies which talk about what the imaging picture in such cases would be. And as you see here, the involvement of the medial temporal lobe is going to be a recurring phenomenon that occurs in all cases of encephalitis, most if not all. And of course, this is another case of seronegative autoimmune encephalitis, not very different from what I showed. So, with this, I essentially would like the audience to understand that it's going to be a three-step process, right? When you have a possibility of autoimmune encephalitis, the first step is going to confirm the structural imaging finding, the EEG, and also possible, PET, because PET is really going to help you, particularly in cases where the structural imaging is pristine. Then, of course, we rule out the differential diagnosis and confirm inflammatory cause by having a look at the lumbar puncture, the blood test, as well as, some cases, perhaps you would get a brain biopsy. But the whole point of being a good radiologist is to avoid invasive procedures. But in some cases, where we are at loss of what's happening, a brain biopsy could help. And then, of course, like I said, always run, search for the underlying neoplasm, because getting rid of that is really going to be very helpful for the patient. And anatomic locations, now again, this is something that is very variable. I hope I've covered at least the commoner manifestations of uncommon as well as the uncommoner manifestations of common conditions. But having said that, I will say that point of this talk is to also let you know that some of the demyelinating conditions that we talk of, and also autoimmune endotheliopathies like SUSAC, are also at the intersection of infection as well as immunity. Now, again, what's really important is that SUSAC, unlike multiple sclerosis, could have a very, very similar, strikingly similar clinical presentation to an autoimmune encephalitis. But what's important that we understand is that we shouldn't be calling this MS. I will say that I know a bunch of people, and perhaps even me in my earlier days, I would have called, a certain imaging manifestation as run-of-the-mill multiple sclerosis, but we know better over time. But this also is an autoimmune condition, essentially an endotheliopathy, which affects the precapillary arterioles with subsequent embolization to the brain, retina, and ear. And again, why I say this is because when the clinician tells you that, the patient has sensorineural hearing loss and some visual manifestations, that really should trick you, should help you into giving the diagnosis of SUSAC. Now, this is one of those conditions where you see that the diffusion restriction here is very unlike what you would see in a demyelinating plaque. A plaque is going to have peripheral trace hyperintensity, but all in the early stages. Here, essentially, what you see is a manifestation of the endotheliopathy. And of course, you have the snowball lesions in the corpus callosum. Sorry. And you can see here, some of the lesions, the orientation is perpendicular to the ventricular system. And that's possibly why, a certain sect of radiologists could confuse this to be SUSAC. But again, very important that you go back and look at what's happening at the level of the diffusion, which of the areas of the brain, which other areas of the brain are involved. Is it the calypso septal interface, or am I looking at different areas of the corpus callosum that are involved? And then also take into account the multitude of clinical manifestations that these patients could have. Now, again, MOGAD is another one of those conditions where, of course, we all know that it's going to be an antibody mediated, perivenous demyelination. But what's really important to understand is that the clinical manifestations of these patients could be very, very similar to encephalitis. And as you see here, this is, the very famous entity flames. So essentially, this patient is just a 17-year-old boy presenting to us with seizures, and the onset was a little dubious. So we didn't know what we were dealing with. The clinicians weren't very sure what was happening at this point in time. They just knew that it's something seizure. So they got the the CT done. We looked at the CT and we thought, is it possibly subarachnoid hemorrhage, or are we looking at meningitis? But it's unilateral. We went back and asked for history of trauma. There was no history of trauma. We thought, okay, it's the first episode of seizure, so we better get an MR as well. And what we saw on FLAIR, I really want you to pick on on this particular finding, because in addition to what you see on pre-contrast and post-contrast FLAIR, where you see sulcal enhancement, you do see the subcortical T2 FLAIR hypo intensity of this area. Now, this is something which I have seen in a few other conditions, particularly hypoglycemia, metabolic conditions as well. So this is also, I would say synonymous to flames. And the important thing to understand is, because of the cortical involvement here, the patient could have cortical encephalitis like presentation. And particularly in the context of unilaterality of this condition, you will have to raise the possibility of MUGAD and have them run it up as well. And this is another one of those cases where we were quick to give a differential of flames here, because we always get better with every case that we diagnose wrong. And as you see, this case also has the subcortical flare hypointensity. Just compare it with the contralateral side. I think my biggest takeaway as a radiologist is symmetry, right? We are we are trained. I think it's an acquired taste among radiologists to correlate everything with symmetry. And as you see, you do see some amount of sulcal enhancement, and SWI could also be helpful because, as you can see here, the deoxygenation is not as great as opposed to what's happening on the contralateral side. And this is a follow-up after 2 years, absolutely normal looking brain. So it's very important to understand that MUGAD is one of those conditions that responds dramatically well to treatment. So picking on the diagnosis becomes supremely important, because your patient is going to have a far better prognosis than calling it something else. Now, having said that, I will also share this case where we had a 6-year-old child presenting with optic neuritis and also a few other manifestations of encephalitis. And really, what we saw here was the cortical subcortical involvement. So, when you do see cortical subcortical involvement, you can have a cortical encephalitis like presentation. You could have a demyelinating condition presenting to you with that kind of presentation. And also, you see the involvement of the basal ganglia on the left. So that could also contribute to why the patient presents with an encephalitic pattern, which could probe you into giving a differential of, say, ADEM or a MOGAD, or a bunch of other conditions. Now, this is one of the penultimate cases. Now, this is the case of lupus encephalitis. This was a young female that presented with neuropsychiatric symptoms. And as you see, this has been running for quite some time. Now, why I say that is, in addition to the signal changes that you see on FLAIR, you also see the extensive volume loss. And just look at how shrunken the brainstem is. So you know that, these patients are not going to be faring well over a period of time, even with, good therapy, or, early institution of therapy. These patients will not have a very good prognosis. So now I come back to the first case that I showed, and I would like the audience to tell me exactly what's happening here. I have spoken for over an hour, and I just want to understand what the audience is thinking here. Are we looking at an infection? Are we looking at inflammation? Of course, inflammation, yes. But what are we looking at? Are we looking at multiplicity of organism? Are we looking at an autoimmune condition? Just going to quickly see what's happening in the chat box. Oh, fantastic. We have Jaffer. He says it's granulomatous herpes encephalitis. I hope that's for the first case. That was a fantastic. Um, Yes, right. So I think that was a fantastic pick, and but I will also say that this condition also turned out to be positive for NMDA. So we could have autoimmunity and infectious encephalitis. Particularly in the case of herpes, you will have the patient come back to you with a recurrence of symptoms, and we often think along the lines of it could be the same virus that is affecting the brain, but it's very important that we go back and look at what's happening at the level of the antibodies as well, because herpes is also notorious to have co-infection with an NMDA encephalitis like picture. So this is my takeaway, essentially what have been the recurring theme throughout the lecture. Of course, like I said, demography also changes when it comes to the infectious etiologies, but more or less, this is how I would approach any patient presenting to me with encephalitis. So, with that, I end my talk. Thank you so much for your patience throughout the lecture, and I'm open to questions now.
Thank you so much for the presentation, Dr. Ahmed. It was really insightful. You have really helped us to reinforce the fact that we need to do a sort of integration of our imaging findings with the clinical presentation and laboratory tests to help us to improve our diagnosis. Thank you once again for giving us all of these practical insights. So we'll go to the question and answer section. You can drop them in the comment section. You can also send them to our email, where Dr. Ahmed, please, would like for you to uh, give us your email so that some people can reach out to you
Yeah,
for some
I'll just
questions.
leave it on the chat box. I'm guessing I've exhausted, the cerebral reserve of the audience here, but I've left my email ID on the chat box. So please get in touch with me. Um, I am also on LinkedIn. You can find me on LinkedIn or Twitter. DM me. I'm open to any sorts of insights, any difference from any experience with cerebral malaria. I will say that we don't see a lot of cases of malaria, but there is a section of our country where we do see malaria. With malaria, I would say that the clinical picture and is particularly the imaging manifestations are very similar to what I showed in dengue. A lot of microbleeds. You could have cortical, subcortical areas of involvement as well. I have seen ANEC-like presentation with cerebral malaria too, and having said that, I did see a case where we just had cerebralitis and brainstem involvement with cerebral malaria. So, but we do not see it quite as often. One of the reasons why I didn't want to speak too much about something that I'm not an expert at.
Right. Thank you very much. I have a question of my own.
Absolutely.
Okay, so
Please go ahead.
all right, so when the clinical information provided by the physicians are not very comprehensive, or if a center doesn't have like access to some of the lab tests to help make a distinction between the different types of encephalitis, would you say that following just like the lesion distribution and enhancement pattern would help us to narrow down the diagnosis?
Oh, absolutely, absolutely. I will say this that I have the privilege of working at one of, the premier institutions of the country, and much like what Professor Godwin says, we have access to extensive imaging tools that possibly are not available in the whole of our country as well. I do know that PET is not something that is, attached commonly with autoimmune encephalitis. So in these conditions, like I said, the whole point of showing you all of these cases is to show you the lesion distribution, and also to show you that infections are going to have this predilection to hemorrhage. They're going to have certain areas of the brain that have, more predilection to infectious conditions as opposed to autoimmune conditions. And also the fact that longitudinal imaging, how important longitudinal imaging is. With autoimmune encephalitis, it's just going to be volume loss, right? But with infections, it's going to be cystic encephalomalacia, cortical laminar necrosis, and essentially liquefactive necrosis, and also the cortical melt sign that I showed in some of my cases. Having said that, also going back and looking at the CSF picture, which I guess is something that is very commonly performed pan global. So also looking at what's happening at the CSF is also going to help you in picking out whether it is an infection versus whether it is an autoimmune condition. I think I did prepare, uh, uh, an algorithm of sorts where, I did define if it is, this area of the brain that is involved, think of all of these conditions. But unfortunately, I've just gone way ahead of time, so I didn't want to show it. But I wouldn't mind sending it to you over email, and, you could just tell me if that is helpful to you, because this is my very finite understanding of encephalitis over my 8 years of being a radiologist. And of course, we are perennial students, so I would want to learn more about how you deal with such conditions, particularly in the context of resource limited areas.
Thank you very much. I will reach out to you via email.
Oh, yeah, it would be my pleasure.
Yeah,
Okay.
I just want to add my voice to say, Sabha, we are so excited, so pleased, and grateful for your presentation. Thank you so much.
Thank you so much. Thank you so much for the invitation. I hope I did justice to it, and would love to hear your experience, and we could collaborate as well on research and other conditions that you would think are common between your country and our subcontinent as well.
Of course, definitely. We'll reach out to you. Thank you so much.
Yeah, thank you.
And I want to thank everybody for attending. It has been an excellent session. Thank you so much.
All right, everyone. Thank you for joining. We have come to the end of this month's session. We will see you again next month. Have a wonderful evening. Thank you very much.
Thank you.
Thank you all. Thank you so much.